Hello and welcome to Webinar Campus Anesthesiology. Today we are having a special session. This week actually we had the DNB National Board exams practicals conducted, and we were focused on this exam because most of my friends were appearing for these exams. This exam actually had some peculiarities because that was the first exam getting conducted with the OSCE pattern. That was one factor in it, especially because of this COVID concerns. But yes, most of my friends were apprehensive, but we had a very good backup from National Board of Examinations. In fact, they took very nice initiative to orient all the candidates regarding how this OSCE session is going to be conducted, and they gave enough orientation, and we had some discussion, and we were speculating how the questions will be, and I personally tried to give you some sample questions and tried to emphasize that the 2.5 minutes for a part of the question or 5 minutes for one station is fair enough time to think, plan, and attempt those questions. In fact, after the exams, most of my friends gave good feedback saying that they were comfortable with regard to the timing. And in fact, we circulated one Google form to collect the feedback on how exactly the candidates felt while taking the exams. And basically the idea is to give better idea to the forthcoming people. They are next batch people who are able to or planning to take the exam in the very next session or subsequent sessions. And hopefully whatever modifications National Board will incorporate will also be informed to the candidates through these mechanisms. I understand that the exams were well conducted in all the centers without any exceptions, and those who spared their time to give the feedback, in fact, told me that they were 100% happy with the exam arrangements. Okay, there were no confusions, they were all made comfortable. So, and actually in that questionnaire, I asked them to write down the questions, especially the OSCE questions, from their memory, so that subsequent batch candidates will get an idea how these OSCE questions appear exactly. So in this today's session, I'm not going to give you an authentic list of OSCE questions, because these questions were written down from the candidate's memory, and National Board has not officially released the questions to my knowledge. So the idea is not to discuss all the questions and answers, but just to have an overview of how these OSCE questions will be even for the subsequent sessions. Okay, I'm also happy to announce that maybe the critical care medicine and other acute medicine specialties exams are coming up, and many university exams for MD, diploma in anesthesia, it's also coming up in the subsequent days or weeks. So Webinar Campus is happy to announce that we'll be having a special webinar tomorrow on basic and cardiac life support guidelines. And our webinar is designed in such a way that we have incorporated the guidelines of American Heart Association and European Resuscitation Council, and we'll see how the Canadian and Australian guidelines follow or comparable to the popular guideline, that is American Heart Association guidelines that most of the institutions follow here in India. The specialty of tomorrow's webinar will be a live video demonstration of the essential skills in resuscitation, like chest compression, defibrillation. We'll introduce you to the AED machine, defibrillator and related skills, post-resuscitation skills. All of these will be packaged into maybe 1 hour, 1.5 hour session, which will benefit all the exam going candidates and all the practicing people or the presently doing postgraduates. They will also benefit, because the more choreographically you do the cardiac resuscitation, when your team members do everything as per the protocol in a proper way, your outcome is going to be better for sure. So tomorrow we'll be joined by Dr. Nigel from Sultan Qaboos University Hospital, Muscat, Dr. Anup Kumar from Baby Memorial Hospital. I'll be joining, and our webinar will be associating with Indian Institute of Medical Sciences, IIEMS, who is the authorized training center for basic and advanced life supports. We'll get all the skills demonstration from the IIEMS training center. So that's going to be aired at 3 p.m. tomorrow, the Saturday, 3 o'clock. We'll be starting the webinar. So be with us for this special webinar. Okay, thank you for filling the profile questions in the initial part of this poll. I understand that there are some people who already took the exam on the last Tuesday. They are actually free to raise your hands. I'll enable your microphone. You can share your thoughts so that the forthcoming batches will be better equipped. So I'll be checking the participants list. If you want to raise your hands, you can share your thoughts and give your pieces of advice on how you felt taking the OSCE sessions. Okay, we'll take your opinion straight away. I want you to, those who have taken the exam, please fill in this form, respond to this poll regarding how you felt regarding the overall conduct of these exams, because we were all apprehensive how it's going to be. Okay, fine. So as per my questionnaire, the general feedback was the exam arrangements were good, and without any exception, everybody said the exams arrangements were satisfactory or wonderful. Many of them, the stress or tension was fully relieved on starting of the exam, because they were comfortable, they were made comfortable by the invigilators in the exam hall. Okay, OSCE was a new exam, new pattern. So my idea is to discuss OSCE questions asked during the last exams. So the third poll questions are coming up. I'll wait for a few more seconds. Basically, we want to know whether the OSCE question, the duration of time allowed, was in fact acceptable, adequate, or whether it is acceptable for all OSCE stations. Yes, there were rest stations after every 7th OSCE station. And after having taken the exam, after going through the process, what exactly do you think will be the better strategy for OSCE? The second question, you can have more than one option ticked. Yes, you can go ahead. I'll wait for another 10 seconds or so. So this is an open forum where you are allowed to come out with your views, advice, or how did you feel about the OSCE questions. Again, reminding you, this is not the official question set. This question set has been collected from the candidates who attended the OSCE from their memory, whatever they have jotted down. I have made it. The idea is not to discuss the question per se, but to focus on which all topics you have to stress while reading the topic very next time. This is applicable for those who are planning to take the exam in the next session also. Okay, so the general feel is the time duration allowed for OSCE questions were adequate for most of the OSCE questions. After going through the list of OSCE questions, I accept that some of the questions were little demanding. So that you have to anticipate whenever you are going for any quality examination, because the exam also tries to figure out who all are the best candidates. Okay, so there may be testing questions that will be there, but overall the feel is I think even more than 75-80% feel that that duration was adequate. So the candidates who are trying to or planning to take the exam next time, they can be relaxed, they can be reassured that 80% of your senior colleagues believe that you will get enough time for each OSCE station. And regarding the best strategy, yes, I think many of them are voting for practice answering to the point. That is something special about OSCE. This is an objective, structured examination, so you won't get credit by beating around the bush. So if you are asked a question regarding compare what is different from Allen's test to modified Allen's test, you cannot write too many things. You have to give the exact difference between these two. Even for drugs comparison, if you are asked to write enumerate drugs causing pain on injection, on IV injection, you have to give answers like 1, 2, 3 like that. You cannot write on the mechanism of pain or the methods of alleviating pain. So you have to practice answering to the point. But again, it's a good habit. Even in your academic discussions, try to answer to the point, because most of the time, even for case discussion, if you are asked to describe your preoperative evaluation for ischemic heart disease patient, people will start from airway, comorbidities, allergies, and all. So you have to be more specific. That should be part of your academic culture, especially when you are doing a specialty post-graduation. So you are all grown-ups, and it's not a big deal if you practice it in your daily clinical practice also. Okay, plan your answer before starting to write. That's what we have been trying to emphasize. You take some 15-20 seconds to plan your answer and start writing, rather than striking off whatever you have written in the first 1 minute, 1.5 minutes. It will not give a good impression to the examiner. Okay, again, rehearsal, proper rehearsal also many people are advocating. 40% people are telling proper rehearsal OSCE to get used to the format. Yes, whenever you are racing against time, though we have enough time, your mindset should be appropriate to the exam pattern. So in that sense, proper orientation and rehearsal also matters. Okay, so these are the advice from your senior colleagues who actually took the exams. So now we'll go through some of the questions. Remember, this is not a session to answer all the questions, just to go through which all topics their questions came from. So I think everybody remembers, whoever has noted down the questions, they remember this question: emergency laparotomy for a trauma with ongoing peritoneal bleed patient. So the sub questions will be pre-op investigations, your monitoring standards, and anesthesia concerns. This is an expected question, and much discussed topic also, maybe with the further details, clinical details from the history, which might have been there in the OSCE question. The answers should have been more straightforward. So my piece of advice is when you are focusing on this topic, please revise your knowledge on the trauma survey, primary survey, secondary survey, how the trauma survey is taken care of, and what exactly is the role of anesthesiologist in a trauma team. The ATLS guidelines, the latest guidelines, you are expected to be updated, and you might get questions. These are not questions, to my knowledge, asked in this OSCE, but for subsequent OSCEs, you should also be ready with a pinpoint answer on what exactly is massive transfusion protocol, and how you carry it out, what are the positives, negatives, and airway management in trauma is a much discussed topic. Flow volume loop was shown, I believe, and after giving a particular flow volume loop, candidate was asked to give the findings, explain the findings, diagnosis, and the scoped out pattern. I think it was regarding a COPD, and the chest X-ray finding for COPD was the next sub question. So you should be familiar with the flow volume loops. I usually tell my junior colleagues to be familiar with the markings in the axis, what you mark on the x-axis, y-axis, how you mark the gradings, where exactly you start the curve. Everybody will be remembering the shape, but where exactly you start, where is the FRC, where is the vital capacity, you should be knowing. Without knowing that, just by knowing the figure itself, you cannot draw. Again, you should be thorough with it. This is the normal flow volume loop. This is for obstructive lung disease, and this one is for restrictive lung disease, where all the lung volumes are less. Okay, you should be knowing the classic chest X-ray findings for a obstructive lung disease patient and a restrictive lung disease patient. I think I have uploaded a video on pulmonary function test with lots of examples. And even I think I remember I have uploaded a PDF document also to give the keys to that questions. From equipment and anesthesia machine, the medical gas cylinders, the different sizes and safety features were asked, and the cracking of cylinder was specifically asked according to my information. So this table you should be familiar with, and these are the safety features with the medical gas cylinders, the color coding, the label, the chemical symbol, the pin index safety system. There is a safety relief valve, and it's been filled within the service pressure. And all the OSCE sessions, maybe next time after the COVID concerns are over, you may be asked to demonstrate how you do the cracking of cylinder, but I'm not sure. It's up to the national board to discuss. So you should be knowing how to demonstrate the opening of a cylinder, mounting of a cylinder, and the mounting of a cylinder ends only with seeing the pressure gauge value and then closing the cylinder, okay, which is very important, the skill. And this table you should be very familiar which size cylinder is used. Mostly E size cylinders are used in the anesthesia workstations nowadays, since pipeline connections are very common and we are very much used to it. Most of the time we forget about the cylinders, but it should be a routine practice to check at least oxygen cylinder, whether it is available, or make sure it is at least half full. Desflurane vaporizer, I think there was a question asking about what is saturated vapor pressure, define boiling point. I think the other webinar we have already discussed these points, and 4 features of tech vaporizers. That webinar actually we have emphasized the saturated vapor pressure, SVP, changing with the temperature, and the moment it reaches the atmospheric pressure that of 760 millimeters of mercury, it attains the boiling point. Again, we discussed how the change in altitude changes the boiling point, because the atmospheric pressure or ambient pressure comes down. So at lesser temperature, the boiling happens. Again, in the last discussion, we have explained how this same graph can be used to demonstrate why exactly you need to have electric heating for desflurane, whose saturated vapor pressure is almost 690, very close to the atmospheric pressure, but still you need to have a supplied heat mechanism for thermocompensation. So these are the expected questions, and in case next time skill demonstration station per se comes, you may be asked to show the filling of desflurane vaporizer, how the desflurane bottle is attached to the vaporizer, how it is filled, whether you will close the dial. These are the observation points. So now onwards, since OSCE is going to be permanent fixture in the national board exams. Better be thorough with this rather than checking for these clues just before exams. The more you make it into routine practice, it becomes an easy question. Tech 6 vaporizer, they're working, there are different diagrams. This is one of the diagrams. So you should be able to explain how it works by the injection principle and how it is coordinated, regulated depending on the fresh gas flow. Again, most of the OSCEs, you can anticipate questions regarding particular values, comparison of boiling point of different volatile agents. Again, comparison of blood gas partition coefficient, MAC values, any preservative added, especially when you are asked to compare the volatile agents. These points will come into play, and it's a good habit to revise this table again and again so that you can write it almost in the same pattern for your theory exams as well. Defibrillator is a key skill. Yes, tomorrow we'll have a demonstration of the defibrillator, when it is used and how much energy is to be selected. When do you use the defibrillator? It's for cardiac arrest scenarios where you get a shockable rhythm, and what is the role of defibrillation. I think last exam the questions were how do you select the energy in the pediatrics, common causes of reduction in success rate following repeated defibrillation. Either you won't be backing up with the chest compressions, because though for witnessed ventricular fibrillation, pulseless ventricular tachycardia, defibrillation is the answer and you have to start working for it right from the onset. But until the defibrillator is ready to get discharged, ready to give shock, you have to give chest compressions, compression ventilation. That sequence, CPR compression, should go on, because you never know how many seconds you will get. So you don't have to wait till the defibrillator gets charged and then you clear shock, and then again immediately after the defibrillation you have to back it up with chest compression so that coronary circulation will be maintained, coronary perfusion will be maintained, and the myocardium will be loaded with ATP resources. And the success of defibrillation should be assessed only after backing up defibrillation with 2 minutes of or 5 cycles of CPR. 30:2 is 1 cycle, 30 chest compressions, 2 ventilations. So only after finishing 5 cycles, 2 minutes, again you check for the rhythm. The moment you see an organized rhythm, check for pulse, because it may be a case of pulseless electrical activity. Then without defibrillation, you continue chest compression. But if the shockable rhythm persists, you plan for the or institute the second shock. But yes, you have to give or start on 1 milligram of epinephrine every 3 to 5 minutes from that point. Again, 2 minutes of CPR. Again, during the assessment phase, you check for the rhythm. If it is still shockable rhythm, you give the third shock, but it should be backed up by start of antiarrhythmic drug, which is amiodarone intravenous 300 milligram IV push. Okay, then continue chest compression. Then the epinephrine next dose will be due, and you can also consider adding another half dose of amiodarone. But throughout this exercise, your resuscitation is unlikely to be successful if you don't try to address the primary cause, that is 5H and 5Ts. Anyway, we will be discussing. We have a special session for BLS ACLS. So you should be knowing what are the shockable rhythms, what are the medications involved, and why you should give chest compression, what role of CPR in defibrillation. The moment patient goes in for ventricular fibrillation, his survival chance comes down by almost 10% every minute. But if you continue at least chest compression or CPR, high quality CPR, this 10% drop in survival rate, you can modify it into almost 5%. The next question everybody has written down was regarding a case scenario: progressive increase in neck swelling for 4 years, diagnosis, differential diagnosis, Then the sub-questions regarding Pemberton sign, Geoffroy-Dalrymple sign. So thyroid swelling, differential diagnosis, there are a good number of things depending on the age and other factors mentioned in the clinical history. You can choose the most common and most relevant ones and place your differential diagnosis. Pemberton sign, you ask the patient to raise both hands, probably touching the ears. Then you can see the increased facial plethora if there is a superior vena cava compression, or so here it is very evident in this picture. Okay, fine. Eye signs in Graves' disease, favorite questions. You might get it as a sub questions also. I'll be sharing this presentation as a PDF file. These are not question answer file. This is just a collection of topics which are asked in the OSCE sessions, nothing more than that. Okay. So again, I remind you, this is not an official list of the OSCE question, but these are the topics that came up in the National Board exams this week. There was a question regarding internal jugular venous cannulation, right IJV cannulation. The sub-questions were, I think, regarding the landmarks for anatomical landmarks for IJV cannulation, the common complications, and if you find a sudden increase in the airway pressure, what are the immediate steps you are going to take? And there was a specific question on triangle of safety, I believe. So internal jugular vein cannulation, nowadays, most of the resources, even the websites, they are giving ultrasound guided cannulation procedures in their description. But landmarks, anatomical landmarks may be asked positively. If the question is very specific, you have to find the answer and respond to that question accordingly. Okay. So you should be knowing this triangle and the landmarks and the success rate with this Sedilot's triangle method, anatomical landmark method. This is the more common complication, pneumothorax. So the X-ray will look like this, and there are other complications as well. In case this happens, there will be a sudden increase in the airway pressure. Then you have to auscultate and check for the other signs of pneumothorax, like limited air entry, restricted movements on one side. These things will give you a clue. And if there is a sudden drop in saturation, hemodynamic instability, you try to decompress by doing a needle thoracostomy first, while planning for an intercostal drain insertion. Intercostal drain, chest drain is a favorite topic, not even for not only for OSCEs, but also for the Viva session. So they'll be asking about the triangular safety, how you position the patient for intercostal drain insertion, and how underwater seal works. So these questions you have to anticipate and prepare accordingly. I think in one of the webinars we discussed, I think it's on the webinar dealing with chest x-rays that we discussed. Even this Heimlich valve was discussed on that webinar. And there was a question on cuffed pediatric endotracheal tube, which has been into our practice since so many years. The advantages, disadvantages, and specific advantage for use of cuffed or microcuff endotracheal tubes in the pediatric population. So it's worth taking a review article on this topic and reading, because even during your case discussion, if their patient falls into a pediatric age group, this question might pop up. So it's better to prepare the answer for that. So microcuff endotracheal tubes, a newly designed cuff tube for pediatric patients. And there is literature says the specific advantages. Okay, decrease in the rate of tracheal reintubation with different sizes of uncuffed ET tubes, reduction in consumption of halogenated agents by the ability to use low flow anesthesia if you are using microcuff endotracheal tube for pediatric anesthesia. Again, pediatric ET tube selections, you might be quizzed on that. You should be familiar with at least 2-3 methods of how you decide your first choice endotracheal tube is going to be. This Broslow tape also you should be familiar with, which is a very nice equipment or gadget, we can say, in the emergency room and in the pediatric OT. Depending on the length of the baby, you will get all the details, your drug doses, emergency drugs, and your endotracheal tube size and all. So you will get from the Broslow's tape. You should be familiar with it. If your institution doesn't have this Broslow's tape, at least you should be getting or reading up from the other resources like online resources. There was a question on posterior cranial fossa surgery, and I think the scenario was like sudden decrease in end-tidal CO2. There were sub-questions on Duran maneuver, Melville murmur, or regarding air embolism. The exact wordings, I'm not sure. I didn't get it through my Google survey. Okay, air embolism is a favorite question during the case discussion also. If you happen to get a similar case, you will be quizzed on that. What are the conditions associated with air embolism? What are the methods to identify the air embolism and the sensitivity? So even if you are discussing capnogram, you will be given a capnography tracing like this when there is a sudden fall, gradual loss of EtCO2 tracing, or a reduction in the EtCO2 value, pointing towards air embolism. And even the Duran's maneuver, the maneuvers where which will help you to reduce the embolization of this trapped air into the pulmonary tree. You have to be familiar with it. It's better to prepare your own notes on this Duran's maneuver and how you tackle air embolism, venous air embolism, especially if you are giving a neuroanesthesia. You might come across this scenario, so it's better to have this plan preset even before attempting a case, posterior fossa case like this. And Melville murmur, I don't know exactly how the question was framed. So these are details. It's an air embolism when there is a large intracardiac air embolism. This is heard. It's described as a characteristic splashing auscultatory sound due to the presence of gas in the cardiac chambers, and it's heard throughout the entire cardiac cycle. Again, there was a question on rebreathing with a capnogram, the baseline gradually going up. So this is not exactly the diagram shown there. I don't know, but this is the model. And there were sub questions on the adverse and beneficial effects of rebreathing. There are definitely adverse effects with rebreathing because we don't intend to rebreathe, but some of our circuits we are trying to reuse the exhale gas, which will help us to maintain the economy of anesthetic consumption. Warming and humidification of inspired gases happen with the reuse of the exhale gas, and anesthetic pollution, atmospheric pollution is also reduced by the rebreathing. Again, on airway assessment, many of my friends have written down questions like commonest airway assessment done during the pre-anesthesia checkup. How do you position the patient? How assessor is positioned? And whether phonation is allowed during the assessment. And of course, name the structures grading the Malapati classification. So this picture is very familiar. I think the day one of our anesthesiology days, we start seeing these pictures. So no need to explain too much on it. The patient usually sits upright with head in the neutral position, the mouth opened maximally and the tongue protruded maximally. The observer is seated opposite the patient at eye level, and the pharyngeal structures are viewed with in a well-lit room or using torch. And the patient should not be phonating, because there is literature saying that when the patient starts phonating, the Malapati class apparently shifts to less severe ones. Maybe the initial ones are maybe 3 or 4. With phonation, it will look like it is 1, 2, or 3. That is the problem. But if the posture is not taken care of, if you assess the Malapati in supine position, the opposite happens. See, even the Malapati real in upright position, 1 or 2 might look like 3 or 4. So if you want to have a proper assessment, you position the patient properly. The observer also should be positioned properly. Phonation should not be allowed, and then you grade the myolepathy class. There was a question on thyromental distance and its significance. So the definition, you should be thorough, and the implications. It's a very simple test, but if you are asked to measure the thyromental distance, better have it measured using a scale. Upper lip bite test was a sub question, I believe. This is another simple test with very good sensitivity and specificity. The class 1, class 2, class 3, you should be familiar. Again, from pharmacology, the anesthetic drugs, there were some questions. I think most of the questions were expected questions. Drugs causing pain on injection, drugs causing methemoglobinemia, drugs implicated in malignant hypothermia, and there was a question on contraindications of thiopentone sodium. The drugs causing pain on injection, definitely propofol comes to our mind suddenly. Rocuronium is in the list, and Etomidate is also in the list. Drugs causing methemoglobinemia, prilocaine and benzocaine. I think right from our pre-PG entrance days, we are familiar with this answer. Drugs implicated in malignant hypothermia, the volatile agents, and suxamethonium, decamethonium. Contraindications of thiopentone, I think we were asked to write 4 contraindications. So acute intermittent porphyria is one of the contraindication. Hypersensitivity to thiopentone is definitely one. And relative contraindications, use of thiopentone with extreme caution in patients with respiratory, cardiac, circulatory, renal or hepatic dysfunction, severe anemia, patients in shock, mixed edema, and status asthmaticus, because thiopentone per se can worsen these conditions. There was a station, I think, on Etomidate, asking for which chemical group does it belong, what is the preservative, what is its effect on PaO2 or PaCO2, I'm not sure, side effects, and mention the induction dose. Regarding chemical group, it is carboxylated derivative of imidazole. The preservative is propylene glycol, because the preparation is 2 milligrams per ml solution in 35% propylene glycol. Effect on PaCO2, the most characteristic effect of IV Etomidate on respiratory system is slight elevation in the arterial carbon dioxide tension. The induction dose is 0.15 to 0.3 milligrams per kg, but in presence of profound hypotension, you go to a lesser dose, 0.1 to 0.15 milligrams per kg. Because Etomidate, most of the time we prefer when there is a hemodynamic instability. The advantage, rapid onset and offset, hemodynamic stability with no significant changes in blood pressure, heart rate or cardiac output, a little bit of anticonvulsant properties, and it reduces CMRO2, cerebral blood flow, and intracranial pressure. So for OSCE, if you can shoot pinpoint for answers, then you save a lot of time. That is one of the messages. The side effects, you should be able to, again, if you can write in a listed format, you save time. High incidence of post-op nausea, vomiting, in contrast to propofol, pain on injection, involuntary myoclonic movements, absence of analgesic effects, transient acute adrenocortical suppression, which I think everybody will be remembering. One station was on EMLA cream, I believe. Questions were on maximum dose, when do you apply to uses in pediatric anesthesia, mechanism of action, side effects of prilocaine, precautions to be taken prior to its use. I think there was one scenario discussion regarding cleft lip and palate. When do you take the patient up for surgery? Which one first? And the rule of thumb was asked to be explained. IV fluid requirement and calculation, the associated symptoms with the cleft lip palate, nerve block for cleft lip, which is a very common question even for during your case discussion, differential diagnosis, intraoperative sudden increase in airway resistance, 4 possible causes you have to enumerate. And I'm not sure about this, how this question was asked. Anyway, it is regarding the use of ultrasound in anesthesiology. Maybe a ultrasound picture at the level of thyroid was shown, and there were sub questions regarding which frequency ultrasound probe we are using and its clinical application, and to identify the structures. I think some of my colleagues are doing their dissertation on the airway dimension calculation or prediction of the endotracheal tube size from using ultrasonography. So this particular part, anatomy, you can be more familiar. You should be able to identify the parts labeled and asked during the OSCE station. Tab block, what exactly is tab block? It is transversus abdominis plane block, TAP block. And if a picture like this is shown, you should be able to point out which layer is what and where exactly you are planning to deposit the local anesthetic drugs. So boundaries of the triangle of Petit was asked, and there was a scenario again on pulmonary embolism post total hip replacement under neuraxial blockade, developed chest pain, tachycardia, tachypnea, and hypotension. What prophylactic measures could have been taken? The predisposing factors for deep vein thrombosis. Again, there were questions regarding the prophylaxis of by low molecular weight heparin. How do you time with your neuraxial blocks? I think there was a scenario with arterial blood gas values, which according to most of my friends was metabolic acidosis. It was not a DKA scenario. So causes of anion gap metabolic acidosis management, and when do you actually start on bicarb therapy, and what are the negative effects or complications of bicarb therapy? Okay, there is a huge list of normal anion gap acidosis and high anion gap acidosis, and how to read blood gas analysis report we have discussed with the 7-step method. There was a question on ventricular tachycardia. What is the pharmacological management of ventricular tachycardia? QTC interval, how do you measure QTC interval? And to list 4 drugs that can cause QT prolongation. So the management of ventricular tachycardia per se, it's you should be very thorough. What you are going to do immediately on getting a case of ventricular tachycardia. And again, then you go to different options, your pharmacological options or electrical cardioversion options, and how you are going to carry out the pharmacological options, how you are going to continue with your electrical cardioversion. We already discussed the steps of electrical cardioversion, CCC, SSS, that is consent, cannula, crash card to be ready before attempting cardioversion, and shock, sync button, and sedation, sync button, and shock before you proceed with the cardioversion. And the moment patient becomes pulseless, you switch over to ACLS algorithm and continue with the ACLS protocol, instituting defibrillation, because pulseless VT is a shockable rhythm. The pharmacological agents choice, lidocaine, procainamide, and amiodarone. QTC interval, the proper definition of QT interval, and how you account for the heart rate to make a comparable index called QTC or corrected QT interval. And the drugs from anesthesia side, we have a lot of culprits like halothane, fluorine, isoflurane, ondansetron, succinylcholine, droperidol, azithromycin, erythromycin. High flow nasal oxygen therapy. This is actually fast getting into our routine practice. How does it help your patients? The advantages and which all group of patients it's preferred. Again, I don't know the exact wording of the in the OSCE, but this was the topic. So you should be familiar with this topic, high flow nasal oxygen therapy. The mechanism, how it washes out nasopharyngeal dead space, how it optimizes the conditioning of the gas by adding water molecules, humidifying it, and positive distending pressure offered by the HFNO therapy. The advantages can be listed out. If you have a prepared table like this, you can have save time and be relaxed, because this question you have to anticipate in subsequent OSCEs as well. The indications, special populations, initial therapy of acute respiratory failure, management of difficult airways, it's something we can use to avoid or delay the hypoxemia onset. improve the gas exchange post-abdominal, post-laparotomy or cardiac surgery, post-extubation and immediate pre-intubation period in intensive care. This is to facilitate bronchoscopy. Can be used in some patients deemed not suitable for intubation or patients just requiring palliative care. HFNO is one of the options. And as a long-term home therapy in COPD patients, you can choose HFNO. There was a question or station on geriatric anesthesia, your concerns in the pre-operative assessment, how you check the cognition, function, nutrition. Mention the task to be performed in the sequence to the timed up and go test. This was new to me, to be frank, tuck test. So I searched the literature. This is how it is done. It's a simple test used to assess a person's mobility and requires both static and dynamic balance. It uses the time that a person takes to rise from a chair, walk 3 meters, turn around, walk back to the chair and sit down. During the test, the person is expected to wear their regular footwear and use any mobility aids that would normally require. The shorter the time, their score is better. If they take long time, it says their ability is less. Wonderfully, so I saw a question on PPE kit. What is PPE? The full form of the abbreviation, personal protective equipment. What are the usual components of a PPE kit? And the process of wearing and putting off, donning, doffing was asked. And not sure if buddy system in use of PPE was asked. It's fantastic. If you are not prepared, you won't be able to answer this. So maybe for next exam, this will be added to our question bank. Okay. You can go to a standard organization like ICMR or WHO guidelines. What are the components of a PPE kit and the procedure for donning and doffing? The buddy system is something that you should know and practice, not only for the exams. Okay. So you should have one buddy helping you for donning as well as doffing, and that person also should be wearing proper PPE. Okay, there was a question on arterial cannulation. I think last OSCE session we discussed about arterial cannulation, including how the transducer works and the physical principles and all. I believe the questions asked in this exam was related to common arteries used, which is the best site and why, regular indications of arterial blood gas, modified Allen's test, and use of anticoagulants, how much heparin you are going to add in the fluid. So it is nice to know the Allen's test, how to describe the Allen's test proper and to distinguish it from the modified Allen's test. Of course, what exactly you mean by a positive modified Allen's test? A positive test will be when there is a persistent pallor in the palm, indicating that there is no collateral blood flow to the hand.